as a kickoff. David, are you happy to start? David, I think, will run everything that he needs to himself. David's a GP in Oxford, a portfolio GP. He's the clinical lead for the Time for Care programme, which works for NHS England to support practices and PCNs around the country. He's hugely experienced in quality improvement and innovation within primary care and healthcare. We're really grateful to him to join us, having spoken to lots of our next gen groups before, to bring some of his wisdom to bear on this particular COVID relevant topic. David, thank you.
Thanks, Will. As Will said, I'm a GP in Oxford, salaried GP. I do 2 days a week now in practice, and I'm the clinical lead for something called the Time for Care programme, which you may have come across, or you may not. And my real interest is in system improvement, quality improvement, QI. And so I want this to be a very practical session. I'm hoping that I'll make you think a bit differently about some virtual meetings and digital engagement, and that I'll give you some practical things to take away with you. Fingers crossed. And then I'll be handing over to Rupa. She'll introduce herself when we come to that, but she's going to talk you through how she's used tech to allow her to run digital group consultations, which is just a really inspiring story, and I've heard it already and it's absolutely brilliant. So you're in for a treat. So you'll have seen a minute ago I had some ground rules up. So obviously reasonably large group of people on this call, so hopefully you're all muted naturally, and I'm going to use Menti, which I think some of you will have come across, most of you probably. People my age, it's a new thing, but you guys are probably old hat. The code is there. It's also on the slides as we go through. I've got a few questions for you as we go along. And put your questions in the chat box if you've got questions for myself or Rupa. We'll try to answer as many as we can, and Will is going to very kindly keep an eye on that for us both. So moving on, just a quick heads up about the Time for Care programme. Okay, so this is a national offer in England to all English general practices and PCNs, and we're a QI facilitation team. So we do workshops. We now do workshops entirely in a virtual setting. So coaching, facilitation, helping teams to utilise quality improvement methodologies better to improve their own systems. And it's a free offer, or it's a funded offer, I should say, for all practices in England. So if you're sitting in the audience tonight thinking, I'd really love to get on and do X or Y, maybe group consultations after you've listened to Rupa, and you can get a group of people together. One practice is enough to express an interest. There's a link at the bottom of that slide there. I'll put that up again at the end. And the expression of interest just triggers a phone call. So there's no more than that. You don't have to feel anxious about it. If it doesn't come to anything, that's fine. So Time for Care, that's in a nutshell. We support other people to improve their lives, basically. That's our goal. Now, we're going to talk about remote meetings. So if you're like me, you've had more remote meetings in the last 3 months than you've had in your life prior to that. It's a very new thing for most of us. So I just wanted to get a sense check as we start. So if you can go to Menti on your phone or on another screen, and you'll hopefully be able to answer this question for me. I've got some answers. Excellent. Okay, so keep them coming. So this is kind of what I would have expected, really. I guess interesting that I was slightly expecting face-to-face meetings perhaps to be a bit more popular than virtual meetings, but there are definitely pros and cons. And you're feeling pretty confident. That's good. Find them generally reasonably effective, but 3.3. Could we get that to a 4? Could we get to a 4.5? So I'm going to talk to you very much about practical things that we can do as people who might be planning meetings, people who might be sitting in meetings that are planned by other people to try and get better outcomes, essentially. So this is going to be very practical. And I'm going to, so this, you'll still be able to answer, but you will also be able to move on to the next question. So if you could just give me a very short sentence, what things do you like? What works well for you virtually in virtual meetings? And I won't tell you my answers because I don't want to bias you. I would reflect. So it's interesting that I thought the most interesting answer on the previous slide was the comment, there we go, no travel time. So for me, that's the number one thing. I love being able to connect to people and not have to spend sometimes several hours getting there because we work all over the country. And we can meet up with people from all different places. No commuting, there are loads of stuff about no commuting. See people's names, yeah, very good. Carbon footprint, yeah. Flexible, don't have to be in the same place. Could do short meetings, maybe an hour here, hour there. You know, previously if you're going to travel, you'd want to make it a longer meeting probably. Interesting point there about only one person speaking at a time. Interruptions are more obvious, which I think is both a pro and a con. It can be quite difficult to manage that. Get involved even when the children only just got into bed. I'm sure that's true for some of us. Okay, so I guess that's the sort of answers we'd all have expected. So what about things that you don't like? If you're still answering the previous question, that's fine. It will capture it, and I'm happy to share these answers later. Okay, so some tech issues, difficult to interact with people, lack of informal chat time. I think that's really important. I'll come back to that. Rupert made a very interesting comment about that to me the other day. Difficulty picking up on cues, yeah. Oh, I've somehow changed slides, sorry about that. Screen overload, absolutely. It's exhausting doing these meetings. If you're back-to-back meetings all day, as Rupert and I tend to be for the NHS England work, gosh, it can really get to you. More transactional, yeah, I think I'd buy that. You lose the non-verbal communication, yeah, absolutely. Hard to describe, but definitely real. Okay, interruptions. So, I mean, someone said to me the other day, we're all Robert Kelly now, so just look out over my shoulder. I wouldn't be at all surprised to see a child come in at some point. I have warned them, they're all on a very, very strict warning and huge punishments if they come in, but you never know. Hard to connect on an emotional level. So, okay, some really good and insightful answers here. I can't answer all these things. I'm going to try and answer some of them. So, moving on. So, some things that we might want to consider. I've got some more as we go through. You'll notice this, I've not branded this slide. These are really my own personal thoughts in response to Will's sort of challenge here. So, introductions. Do you do them? Do you not do them? It takes up time, obviously. How long do you give to them? What happens when someone rambles on and on and on with their very long biography? Do you put your videos on or not? Some people said about poor technology, what do you do, you know, if you're going to basically ruin the quality of the audio by people having their videos on? What do you do about the lighting and your camera quality? Interactivity. So someone said it's easier because people can't interrupt as much, or at least it's obvious, but actually, how do you manage that? Who speaks? How do you decide? How do you flag it up? Ground rules. I put a couple of ground rules up earlier. I don't like ground rules generally when I'm meeting people face to face, but when I'm working virtually, I find that a little bit more important actually. Breakout groups. I don't know if you've been in meetings with breakout groups. I imagine you have. It can be a really useful way to actually do some work with smaller groups where you can really interact in a more meaningful way and then bring stuff back into the bigger group. And we've got the chat box here today. So do you use the chat box? What do you need to think about if you're going to do that? So those are just a few of the things we're going to discuss. Now I'm going to give you a framework to think about this. Okay, so if you're thinking of setting up a meeting, how might you go about analysing that in advance? So I have broken that down into a simple 2x2 matrix. How big is the group that you're going to be working with? And how strong are the existing relationships? So you can kind of imagine that you're going to have a different approach for a group that knows each other really well and is, even if it's massive, versus a very small group that doesn't know each other at all. And I actually, although it's a 2x2 matrix, I think it helpfully breaks it to 6 sections for me. So small, medium and large groups who either know each other or don't know each other. And obviously there's a middle ground in terms of the relationships that there's a blend between these. I'll share these slides afterwards, and this is not by any means exhaustive. This is just a few thoughts that might be helpful, and I'm going to break this down now, so you don't need to stress about trying to read all these things. Just be aware that I've tried to break it down so that we can have a framework for thinking this through in advance of the meeting. So let's think about ground rules. Okay, now why would we have ground rules? Well, usually we use ground rules with groups that haven't worked together much, because you need to sort of control the behaviours of the group. If the group knows each other very well, down in the bottom right there, and if it's a relatively small group, you may think to yourself, I don't need to do this. This is going to be overkill. The bigger the group and the less it knows, the less people know each other, the more likely you are to need ground rules. Okay, and I'd consider them even for very small groups of people who don't know each other well. I'm not saying don't use them in face-to-face meetings, but I do think they're more important, and they don't need to be extensive. It might just be a couple of points, particularly around how people are going to speak. What about the chat box? So I think the key point about the chat box, and those of you who've facilitated meetings will know this already, if you want to run a chat box, if you've got a reasonable number of people in there, you need someone to help you. So I'm delighted that Will is keeping an eye on it for me. So small groups, I would be happy to run a chat box myself. I had a meeting for about 20 people before this, and I was happy keeping an eye on the chat box, chatting, letting other people talk. The minute you get up beyond sort of probably 15 to 20 people, I think you need someone keeping an eye on things for you, making sure you're not missing important points. If you're going to run a chat box with a very big group, then, and we kind of are doing that today, and I haven't been that strong on the ground rules, but you need to be clear what it's for. And I think that's almost more important when the group knows each other really well. So if you have a group that knows each other and is sort of has long-term relationships, you'll quite often get a lot of true chat rather than work chat in the chat box. So it'll be banter, it'll be jokes, you might get GIFs put in there, and loads of emojis and that kind of thing. And that can be really great in certain settings, but it can be really distracting for the facilitator, and it can also mean that when you go back through the chat, you can't find what you want to go back over. So be clear what you want the chat box for. If you're using the chat box, then if you're using the chat box, then be clear what you want to get out of it. If you want it to be a verbatim kind of comment of the discussion, then you don't want loads of banter in there. Let's think about video. So just very simple, the more people you've got, the less likely you are to use video. Video is really helpful, of course, if we don't know people, and someone talked earlier in the Menti about lack of cues and visual cues. So video is really important for that. And sometimes we need to toggle them on and off. I often toggle mine on to speak in large groups and toggle it off again. So just something to think about. Again, it kind of goes into the ground rules. Another thought, do you want people to speak? So if you have a small meeting, I'd really encourage you to get everyone to speak very early. I'd probably go around and get everyone to introduce themselves. Try and limit it, one sentence, tell us who you are and how your week's been or something. It can be longer if you want, but obviously time adds up. I find it's easier with people that know each other. So if you're in a group where people don't know each other of medium size, I find that people often speak too much. They feel they need to kind of justify what they have to say. They go over stuff. So just to be aware of that, you can still manage it, but you need to be very clear on who controls it and when people are to speak. So there we go. And then breakout groups. So those of you who have used breakout groups, they can be incredibly effective. It's a little bit like breaking into small groups in a workshop setting. Discuss something on your tables, then bring it back into the main room. But it does take planning. So my one bit of advice for you is to not try and manage this on your own. So when we do this with NHS England, the team we work with, we have someone who monitors the attendees as they come in, jots down the names, breaks them into groups, puts that onto a slide, sticks it up, and we've created the breakout rooms in advance so they know where to go. We then show them with screen share, I want you to go into this room now. It is amazing how people get lost. It's a bit like, when you're running a workshop, people go into the wrong workshop and sit down in the speed awareness caused by mistake. Well, it's the same thing happens online. You'll get the wrong person in the wrong meeting. That's life. The easier you make it and the more explicit you are with instructions, the better. So moving on. I've mentioned that top list that's gone small now. Another couple of points. Number of facilitators. do not underestimate the benefit of working as a team, facilitating a virtual meeting. But you can't see each other. So you have to plan in advance how you're going to work that through. Is it the chat box? That can be okay, but then you can get muddled up with other messages coming in. Is it having WhatsApp up? Is it through some other mechanism? Whatever it may be. And whose responsibility is which bit? So chat box is the number one thing, but there may be other responsibilities, letting people in, for example. So it's great to have James in the background doing stuff like that for us. Someone mentioned this in the answers earlier, but you actually don't need to have long meetings. You know, if you're just logging on, you can have a very short meeting, and it's not a waste of time because you haven't had to drive there or walk there. You know, you haven't taken a big chunk out of your day for a small meeting. So frequent shorter meetings, and with the NHS England QI work, we're often doing, you know, a week of meetings, one a day, maybe for half an hour, and we get a lot done in that way. It's really effective. And of course, the first meeting, you might need to do a lot of groundbreaking and getting people to know each other. But as you move on, you can dispense with all the introductions. You just get straight into work. So frequent shorter meetings, I think, can work really well. And longer meetings can be a real bind online as well. We mentioned the reading cues and reading the room. That is difficult. I don't have an easy answer for that, other than watch the video where possible, keep an eye on the chat box, look for stuff, ask people explicitly, put things, so ask them questions, use something like Mentimeter or Slido to gather feedback as you're going along. Gaining agreement, how are you going to do that? So very often in a meeting, the agreement is gathered by looking around, getting eye contact, are people nodding? You don't have that. So just think that through. How are you going to take a vote? How are you going to know that when you come back to the next meeting, people are going to say, yeah, we did agree that, rather than, no, we didn't, which is quite possible. So gaining agreement. And then this is Rupert's, missing the after meeting chats. And someone else mentioned this as well. So this is the soft stuff. This is the kind of slightly social chat. This is the walking back to the car afterwards where actually it turns out, oh, I did vote for it, but I'm not really happy. You need to know this stuff. So how are you going to manage that? Who are the key people that you might need to speak to after the event? Maybe just have a brief touch base, quick virtual coffee with in the next week or something, because you haven't got that. People can't sidle up to you as easily. They might not feel comfortable to ring you, for example. Okay, so lots of stuff very quickly. That's my summary slide. I'm going to send that out to you, so no need to write it all down or anything. And it doesn't include everything. I could talk to you for hours about this stuff because I'm incredibly boring, and you'll be pleased to know I'm going to hand over to Rupert very soon. So I've got a couple more questions for you. So what do you think is the most important thing defining the effectiveness of a virtual meeting? So you can rank these, so you can vote for more than one. And I'm very interested to know what you think. I appreciate that they're all incredibly important, of course. I'll give you a minute to have a little look at that. Back into Menti. Okay, so Will, you're off the hook here. No one seems to care if the meeting runs on time. That's good. But yeah, clear decisions. I mean, I think these things probably aren't any different to face-to-face meetings. It'd be interesting to run the other question, I suppose. But yeah, clear decisions. I think that's, for me, that's very important because it's so difficult to achieve that in a virtual meeting, and it does require real thinking through. Right, I'm going to flick on. So, interested to know what you think of this particular discussion. I'm going to carry on with the chat box, but I'll leave that question up there, and in a minute I'll flick it forward and you can give me some comments. And the reason I'm interested is because that framework I've just put up is new. I've just come up with it for this meeting, really. Personally, I think it's helpful, but you may disagree. So I'm just having a look at. It's a very good point about the purpose of the meeting. So yes, a really good point. And of course, meetings are, there are a range of different reasons. So decision making is one of them, but not the only one. So I take that criticism, absolutely. And we've got, what other comments have we got, Will?
Well, David, we had, I was reflecting on the use of multiple facilitators, and I was wondering if you have any experience or thoughts on how you manage that, because I've noticed that there's a sort of split role. Traditional chairing of a meeting, you kind of have that facilitatory role to make sure everyone speaks, get people's voices out, make sure that the conversation is balanced, but also ensuring that the work of the meeting is achieved, the decision is made or the ideas are generated. If you split those functions a bit, which, maybe that's how I was interpreting having multiple facilitators, how do you manage that as the meeting as the person responsible for the outcome of that meeting, the chair?
So I think at the end of the day, you're still going to have one person who holds the ring and brings people in and out as appropriate. So I think you need a chair in whatever you want to call that, a chief facilitator. And you need to, so the point, I can't remember who made the point in there about it just depends on the purpose of the meeting. But, well, yes, that's true. So if the meeting is purely a team building meeting, it's very different to a meeting where we're trying to come up with new ideas for something versus a meeting where we're trying to decide on the next step that we're going to take and we're voting on it. So, so I think I don't have a complete list of all the jobs that I would put, because it does depend on the meeting. But I would say that the number one thing is that someone chairs it, and you can hand that on. So you can hand on from one to another, as long as you're clear in your handovers who's now in charge. And then, so there's obviously the chat box. There may be other mechanisms for getting feedback that are important. And the other thing, so I've sort of touched on this, but if you're going to run virtual, breakout rooms, then you really need people to be all over, getting people into the right place, making sure that they, the list is accurate, that you've got all the people on there. The feedback from those meetings, from those sort of breakouts, can be really difficult to manage. So how are you going to do that? Is it going to be written? So we use Teams, for example. Actually, you can share documents on Teams. People can write in them in real time. We're only starting to use that. There's something called Whiteboard, which is another Microsoft app, which, if people have got it downloaded, works incredibly well for creating process maps and drawing ideas, and everybody can contribute to it. The problem we've had with it is that if you don't have the full version of Whiteboard or Teams, then you can find that you can't see bits of it. And so we're still playing with that. We're learning as we go along, really. So I think I would say, the chat box is the number one thing. Making sure people can get in and out of the meeting. So if you've got 100 people coming to a meeting, it's very, very common to have people ringing our support team saying, I can't get in, my password's got me into a different setting or something. Coming in as a guest versus coming in as an attendee gives you different role in Teams. So that seems to happen quite a lot. So yeah, I think the admin support, the chat box, and then probably feeding back when you've had small group work were my key roles. But if in a bigger meeting, there'd be more.
Thanks, David. There's a fair bit of love for Menti. I agree. I've not seen it work this well before, so it's a really nice.
Yeah, well, it's the first time I've used it with my own slides in as well. So I normally flick between the two, but actually, if you're going to do it online, obviously you really only want to. You don't want to keep flicking between things, because that's so often you get the glitch. Then you can't share your screen properly. So the nice thing about this, it turns out you can put Menti into. You can put your slides from PowerPoint into your Menti presentation, it turns out. So there you go. That has worked, I think.
I had a question. We talked about the different purposes of the meeting, and I've definitely seen virtual meetings effective in decision making. I haven't experienced virtual meetings be quite as effective in idea generation and brainstorming and creative thinking, which I know is what you spend a lot of time doing as part of your quality improvement processes. How have you got around that in the digital space?
Well, sometimes by actually getting the people to do it in the room, because quite often if we're working with one practice, then they can kind of be facilitated by someone sort of, a virtual head on a screen, and they can actually get real post-it notes and stick it up. Sometimes so you can actually use PowerPoint in a shared form. I haven't used it myself yet, but I'm told that if you, there's a shared version of PowerPoint where people can add post-its onto a screen. Honestly, the chat box is often as good as anything. You can, as long as you facilitate that chat box really well and you kind of keep track of the stuff, I think that can work. I think one key thing is to not be afraid to give people a bit of space. So it's been quite uncomfortable for me waiting for people to fill in the Menti questions, because you're sitting there in silence. But you've got to give people time to think, and so you have to just hold their wait, and then it will come. But it probably feels like it's a lot longer than it is when you're face to face. So I just have confidence in that process. And the other thing is being really clear on how they're going to do it. So when we facilitate with a group in a room, we say, right, one idea per post-it. It must be a sentence. You must you mustn't write lots of different things. You must write it clearly. It's the same thing. So if you want them to write ideas, they need to be clear. If you're asking people for ways to improve general practice and they write IT, doesn't help. What about IT? What things specifically? So there's still something about being very clear in your facilitation instructions.
Thanks, David. Yeah, Zarina has pointed out, having held some large meetings with multiple speakers, it's as much about the people in the background, isn't it? As you said, to someone around managing the chat, but also helping bring people out of the waiting room into the meeting, keeping an eye on the time. When you're managing the agenda, trying to look at people on the camera and bring people and manage who's saying what and for how much. There's a lot of different roles. It feels harder online than it does in a room, I think. And
I think it's harder. Is it harder, or are we just not as used to it? So we've all, we've grown up using, being in meetings. Like the whole of medical school is lectures and small groups, and so we're just used to that. We're used to playing in that way. I think what we'll find is there are things that you gain and things that you lose. Okay, and I think we will definitely. So Connor's just put a question about what could we learn about virtual meetings we can take back when lockdown eases. I'd ask that question to the group in many ways. For me, the biggest question for me is, when do you need to meet face to face? So we will do a lot more virtual meetings. So particularly in my NHS England role, if I've got to travel to Yorkshire for the day, that's a lot of travel. That's a lot of time that's kind of dead time, and it costs money, carbon footprint. So we'll do a lot of stuff remotely that and you just have to weigh it up. What value am I adding by being in the room? There will be some. So we're talking about some of our capability building programs where we take people through the sort of skill set of QI, and we run 6-day programs often, and we probably will now run those partly in virtually. So we'll probably get people together so they can see each other, introduce themselves online, very short meetings, maybe over a period of time. Then we'll have a probably 2-day meeting where people stay overnight and they can actually really meet the people they've met online and put a body to a face, if you like. Sounds a bit odd. And then we might go back into virtual. So it will save us a lot of money. And it will save people a lot of time. I think people will be easier to engage with our programs. So yeah, I think it will be flex. It will be a flex model, I think. But the key question is, do I need to be face to face here? And it does add some value. Of course it does.
Thanks, David. Zed was commenting on scheduling in the sort of coffee and virtual time with the sort of downtime with colleagues. I think that is something, Zed suggests something to help make it recurrent. So I think that is something we miss, isn't it? And it's almost like, because you have to book in a meeting, you have to book in a call, you then have to get through the 10 minutes of catch up before you can ask your 2-minute question, and you don't get quite the same relaxed conversation that you might do face to face. but making it recurrent perhaps helps that and builds some structure.
Yeah, so we have rolling coffee meetings that are at set times of the week for our groups, because we're based all over the country, and we can't actually meet up at all at the moment. So there's no face-to-face whatsoever, and we've got 80 odd people in our faculty. So yeah, we've got times in the diary, and normally they get between sort of 6 and 10 people at those, and it's literally just chat. You're not allowed to talk work at all. There's other ways you might do that. WhatsApp's actually quite helpful just for a bit of banter, but it's not the same. So yeah, you have to force it a little bit. But again, is it worth it? Is it not? Some people choose not to join those. It's obviously not adding enough value for them. Either they don't like us, or they just feel actually I've had enough meetings. Thanks. That's okay. But you need to have that offer for those. The people putting in the chat box. Really miss that face to face, and I agree. Absolutely. I mean, the fact that I work in a practice, I can go in there is a godsend.
Thanks, David. So I think we're gonna move on to have a conversation with Rupa now. But any last comments in the chat box, please do put them in.
I'll trawl through it, and if there are any questions that haven't answered, I'll try and pop an answer in at some point.
Thanks. And Arthi, who's a GP up in Manchester, was just asking for any top tips for newly qualified GPs. Maybe they're going to be doing some locuming for a while. Any top tips for improving kind of innovation and QI competency or experience? Have you got any easy suggestions on that while people are putting their last reflections?
So sorry, I was reading the chat box. So I'm being asked how to skill up on QI.
Yeah, as a newly qualified GP.
Well, so the answer to that, I think, is do it. Most people learn this stuff best by doing. So if you're locuming, that is tricky. Maybe apply some of those skills to your own life. Choose a thing that doesn't work for you. You need to define your problem. Can you apply the model for improvement to a problem in your own life? And if you are locuming, but you've got enough of a relationship with one or two of the practices, go to them and say, look, I really, free resource. I'd like to do some QI with you. Can you allow me to do that? I think I'm going to move my son on. I think I've put my email address, hopefully. Here we go. So drop me a line if you're interested. We'll try and find you some support. Time for Care is active in lots of different parts of the country, and it may well be that there's stuff ongoing that you can get stuck into. So, we've got a really, really broad spread. In the last 3 years, we've had contacts with our program with over 50% of practices in the UK. In England. So, we've got lots and lots of contacts, and not everybody likes us, but we've got really good relationships with a lot of people. So, whoever that was putting that question in, drop me a line. I'll see if I can help. But also just reach out, get stuck in.
Thanks so much, David. Thank you. I'm going to move on to speaking to Rupa now. Could you introduce yourself to everyone for us?
Right. Hello, everyone. So my name's Rupa, and I'm a GP from Wokingham in Berkshire. And I've been a GP for quite a few years now, looking at all of you. So it's about 18 years, managing partner. I started off as a GP registrar back in the day in 2001, and then became a salaried, then became a partner, and then a managing partner. I'm also a PCN clinical director, and I work with David on the Time for Care team and been working there since October. And I've just started working with the NHS Confederation as well, and I'm the South East England rep for them. Doing a bit of coaching, which I love, and I've got my family as well, 2 children. I have a teenager in the midst as well, which is all good fun, all good funny things.
Gosh, it sounds busy.
Yeah, it's really busy. It's really busy.
And I'd love to pick up on the new role you've got with Confed, but we particularly wanted to talk about the changes you've made introducing virtual group consultations. I wonder if you could tell us a bit about where that idea came from and what the driver was, why that felt like an important thing to do at the moment.
Yeah, so we were fortunate in that we were already doing face-to-face group consultations, and we'd been doing those for about 18 months. And I was really pleased to see Zed Moore on who's come on, because Zed's given me the opportunity of running some workshops in the Southwest. So we did about 6 of those together. And, it's something that I've really been passionate about, trying to get patients to really learn about their long-term conditions, how to manage them, empowering them to self-care and building up a network of support around the patient, and using your MDT team. And we did lots of face-to-face group consultations, pediatric asthma, chronic pain, diabetes, pre-diabetes, fibromyalgia. And the last one, we tried to spread that across over the PCN. We managed to do 2 PCN sessions of fibromyalgia, and then COVID hit. And we thought, well, what now? Patients were finding it really difficult to get through to us. I think not that they did. I think it was more that they didn't want to bother us. They thought, oh, my GP is going to be so busy, I won't bother them with my usual things. So they've kind of held on. And then there were our shielded patients. You can imagine it must be pretty frightening for them, being quite isolated, being away from family and friends. And we thought, well, let's reach out to our patients. Let's just let them know that we're here. If they need to ask us any questions, we're here for them. And I think it was particularly good for, we have a few staff that are actually self-isolating as well. And for our staff, working from home, doing admin duties and things like that, we brought them back into the workspace, that they had their role, they had their purpose, it was back, and they could then, also help out in this COVID crisis, rather than feel a bit redundant, really, being at home, that they weren't able to partake and help patients.
That sounds fantastic.
Yeah.
What does it look like? What does the virtual group consultation model look like?
So it's really interesting that the discussion that we've just had about what we find good and not so good about virtual group consultations is exactly the same as how patients would see it as well. So if you just think how you would see them, think about it from the patient's viewpoint. We did a number of group consultations. We started at the end of April, and we thought, let's reach out to our shielded asthma patients. So we had a group of us. So we had our new health coach, our social prescribing link worker, myself, mental health specialist from Talking Therapies, our local Talking Therapies. And we got together and put forward maybe 5-minute presentations on our areas, what we were doing in the community, what would happen if, how to distinguish COVID symptoms from asthma symptoms, what would happen if you develop COVID, how do you seek help, reassuring patients that there are services available. There's a hot hub, the 111 that was there at that point rather than the 119. So it was really trying to get patients to optimize their treatment and understand that if they are shielding, what local services are available for them. And then we went on to do an anxiety virtual group consultation. And that was really purely because in our huddles, we have twice daily huddles, the clinicians were saying, look, we are speaking to so many patients that are feeling really vulnerable and isolated at the moment. They're not at work. They don't know what the future is going to be like. They're having panic attacks. Can you help them? So we set up a virtual group consultation for anxiety patients, and we've done 2 of those, and we've got another one in a couple of weeks, just because of the demand. And we have a clinic screen on EMIS, so patients just added onto that as they're spoken to on the phone, triaged by our team. We also have a Q&A on shielding next week, because I think there was a concern because it was getting towards the end of June, and patients would have been thinking, what next? What do I do? So I believe there's guidance just come out today to say that's going to be extended, which is really good news for some of those patients. We did have, unfortunately, some safeguarding cases that had come through because families were so stressed from being isolated, not accessing the usual support networks, the normal NCT, going for a walk with the buggies and all the things that you do when you have a new baby. And so we had some shaken babies. We had 7 shaken babies in our locality. So we got together with our local health visiting team and put forward a postnatal group for the 0 to 3 month olds. It was really well attended, lots and lots of questions. And we showed quite a powerful video on, you can walk away. if the crying just escalated through the video and the father was saying, I don't know what to do, the baby's crying. And so that was a really successful one. And we did one this morning for the 3 to 6 month cohort as well. And we did a child mental health one, purely because, you know, again, speaking to patients, speaking to parents at the end of their tethers, you know, they're trying to work from home, they're trying to homeschool, the stresses are on people. So what can we do to help our community? What tools can we give to them that will help them to care for themselves while we're maybe not around, and maybe they can use those tools to help in the future.
So that's an inspiring range of consultations you've already run. Can I understand a bit about the practicality of it? So Hannah asked a question about what the sort of, how you set the ground rules around that. We were just talking about ground rules, and whether there are any sort of reference guides that we could share that would help with that. And also, you know, what time do they run? Do you record them? Can people access them at different times?
Yeah, so we tend to run them during the day. We did do a webinar, a COVID webinar open to the public, which we did in the evening. But we try to do them during the day just because people have been working from home and it's been really easy to access. If in time, you know, we'll need to put them on in the evenings again, then maybe we will. But I think for our hardworking staff, it is a bit of a shame to get them to do a whole day's work and then say, oh, can you log in at 7:30 as well? But at the moment, it's working pretty well. We don't actually record them because of privacy laws and confidentiality. So we haven't got that kind of permission at the moment. And NHS England have been organising a confidentiality and privacy toolkit that's still in progress. It's almost finished. And we've all had an input into what we think should go into that. So there is training available as well at the moment. It's funded training. So if your practices do want to go ahead and look at implementing virtual group consultations, then you can go on the NHS England website. There's lots of information on there and you can sign up. Coming from July onwards, I think the training is going to be starting.
Brilliant. And in terms of that privacy, you described the different presentations that different members of the MDT gave, for example, in the asthma session.
Yes.
How do you manage the interactivity and between patients and patients with yourselves? And I guess within that, there's a question about size of the groups and how you regulate that.
So the optimum size is about 8 to 10 patients, but you know, you're putting in a lot of effort into texting these patients and getting the MDT involved. So more is better, but you want the one-to-one interaction. So essentially what you're offering patients a bit of information, and then each patient has the chance to come off video and off mute and ask the panel whatever questions they want. And then everyone else in the group is listening in and learning from that experience of that patient. And they probably didn't know they didn't know that question and hadn't thought to ask, but actually reflecting on it, it's something that's really important to them as well. But the important thing also is to bring the other patients in. So you may say, oh, has anyone else had an experience of that? You know, Mary on the chat box has put this in. Mary, do you want to come off video and explain what you did in that situation? So you really want to facilitate the discussion between all the members of the team plus the patients. Obviously, you might have to, you know, interrupt them if what they're saying is not right. But it's really good to get that network built up, and if patients wish to get involved and speak to each other afterwards, that's brilliant as well.
And you mentioned texting patients and patients being sort of recognised as that this might be relevant to them off the base of the list. Can
Yes.
people sign up for it or access it, or is it sort of recommended via the practice that this might be useful for you?
So we do a patient search at the beginning when we decide what our cohort is going to be, and we do that as a team of what we want, which cohort we'd like to target. And then once we've done the search, we have an admin team, and this has been kind of developed with PDSI cycles and team meetings every 2 weeks. of the best way of going forward with this. So we now have a team of 4 admin that rotate round doing roles. So each person has their own roles for that particular cohort. And one person will be in charge of doing the invitations. One person will be in charge of doing a results board. Somebody else might be in charge on the day of ticking patients and consenting patients, and being in charge of the chat box. And I think it is a lot of work if you just leave it to the one person to do everything. And the consent and confidentiality, we go with the NHS England rules and make sure that every patient is identified as being them, having a specific piece of information that they need to come in with. Making sure that you create a safe space, a bit like a consulting room. So I describe it to patients that imagine this virtual room is your consulting room. You need to shut the door. No one else is allowed to walk in and out. You're not allowed to record this. And if everyone feels confident that whatever is said in this room stays in this room, and then we all agree not to break anyone else's trust here, and then we can have a much better, more frank, honest conversation. And that seems to work beautifully. People really react to that and imagine them being in a consulting room. So really positive feedback from patients after they've been to one of the sessions.
Fantastic. I was going to ask about the outcomes data you've collected. Aside from the feedback, have you sort of looked at any other changes in behaviour that have resulted?
So at the moment, it is something that we've only just started, so we haven't got an awful lot of outcome data, but we're certainly looking into it. We're looking at perhaps maybe after the asthma consultation, how many patients have come back with queries. We're looking at how many of our postnatal babies, have there been any more non-accidental injuries, and I can say that there's not been any. There were 7 before and 0 after, which is great. But yeah, that's still work in progress, because I think we've been so busy doing the doing, so we're trying to roll them out once a week. But yeah, certainly I think over the summer we're going to just calm down a bit and go back and revisit. Each group consultation has outcome measures. So for example, the Edinburgh postnatal questionnaire has been sent to everybody that participated, and then we'll send them another one to check the before and after. The HADS questionnaires, the PHQ-9, all of that has been done, the children's anxiety questionnaires. So we're very mindful of making sure that we do collect data as we go along, and then collect it later. And hopefully we'll get the other practices on board to look at their patients to see how many times they've been in before and after, and had they been to A&E, had those that we try to give advice on, particularly those asthma patients, have they had exacerbations? Did anyone develop COVID? So yeah, lots of work to do. And
well, it's amazing what you've done. It really is, and lots of people on the chat sort of sharing that sentiment. I think it's really innovative. Thinking about the privacy bit, clearly that's paramount to people as to what they feel they can share and take. Are there any limits around which apps you use, which software you use to do this? Yes. And how do you support people who are maybe a bit less tech savvy and don't feel confident?
So we have to use Microsoft Teams, and that's the approved one by the NHS. So that's what we use. At the outset, we did have a lot of technical issues. We had lots of patients emailing the next day saying, "Oh, we tried to get on and we couldn't get on. I was in the lobby and no one let me in." All these kind of things, which you just feel awful about, don't you, when you've tried to help patients. And we couldn't understand why. We didn't see anyone in the lobby. What do you do? So we've had a couple of training sessions as a team on Microsoft Teams since, and we've got to know the functionality a lot better. Patients can also just use a smartphone to come in, which is really handy if they don't have iPads or laptops. The only thing that I would say is that the elderly patients haven't been able to contact us as much as we'd like. We were quite hopeful at the beginning, because we heard that lots of elderly people contact their grandkids on Zoom and all sorts. So we thought maybe that might work, but it was a bit difficult. So anybody who's expressed an interest and said, actually, I'm really sorry, but I can't, we would do a telephone call with them. And we've got a wonderful team. We've got 2 amazing social prescribers who have been contacting all our vulnerable patients anyway, and then passing back any queries to us. So hopefully we've got all bases covered on that front.
Thank you. Sean was asking specifically about that aspect of triaging patients into consultations. Could you talk briefly about how you do that and which metrics you use to decide who would be most appropriate for?
What I'm doing, generally is that if I take anxiety as an example, because that's the one that most people are adding patients to. So if patients are expressing, I'm feeling really isolated, I'm anxious about going back to work, I'm not able to talk to people, I haven't seen my parents for a few months. If they're expressing anything to do with COVID, then we would put them into the COVID anxiety group. But, we can also do patient searches and invite patients by text. And I've set up, because of the virtual group consultations, I've set up our practice Facebook group as well. And I'm advertising what we're doing, and people can contact the practice. So we get some through there, and some through other patients through the website. So we've got a list of what we're doing. Going forwards, our health coach, she had her very first one-to-one coaching sessions this afternoon. So I'm really excited to touch back with her tomorrow of how she's done. But she's going to be doing group education sessions across the PCN. The first one, we've called it, "Have you put on weight over COVID? Would you like some help discussing healthy eating?" And that will literally just be a link, and whoever wants to come in can come in and just have a discussion and ask general questions on that. The one after that will be, how to reduce your blood pressure without increasing your medication. We've got diabetes and lifestyle, stress management techniques, things like that, where we're trying to roll one a month. Second Wednesday of the month, we've said 10:30, there'll be something available. If you want to log in, that's brilliant. To try and do a bit of self-care. And I'm hoping at the end of all this, we will see an outcome. We need to be in it for the long haul, really, because this is preventative medicine. So it may be a year, it may be 6 months, it may be longer, we don't know. But hopefully we'll give patients the tools to care for themselves. And we might see a reduction in GP demand, I don't know. Let's see what happens. And at the very least, we can signpost patients and say these kind of things. There are these websites available, or the social prescribing link work is available, or you can see your pharmacist for that. Any kind of ideas. If anyone else has got any ideas, that would be great to hear your ideas as well of what you would do in that kind of situation.
We've had loads of questions, Rupa. We're not going to be able to cover them all, unfortunately, in time. But there was a question from Ling around advice you have on how to introduce this as a new process into the practice. And I suppose maybe picking on that, what were the non-technological challenges you had to overcome to get this up and running? And just to tie in James's question as well, his question was, how do you find time to get it going within the practice, which I suppose probably links.
So I think the non-technological challenges were definitely the time for our admin team. We've kind of fine-tuned it over the weeks by having plenty of meetings and discussion, and everyone in the team is equal. Everyone has an equal say. It's kind of leadership by all. We put processes in place. We've done process mapping, done ideas generation. We've used the NHS model for change to try and get everyone on board and everyone motivated, and using the huddles from the surgery and getting people's ideas in. So it's really, trying to get it embedded as business as usual. This is the way it's going to be post-COVID. We're going to keep doing these things. But it's really, the time and also trying to persuade the rest of the PCN that rather than putting resources into the DES and getting the nursing homes done, trying to invest in proactive care is just as important, because we're very reactive, aren't we, in general practice, because that's the way we've had to be. But trying to understand the benefits and meeting the team as well, and inviting everyone to come in and join us on a group consultation. Here's a link if you want to join us and see what we do, and meeting the team. They met the health coach on Tuesday via a Microsoft Teams meeting, and asked her a few questions about what she feels is going to benefit patients. And how do I find the time? It's because I love it. When you love something, you make the time, don't you? And everything, all the different roles I do all feed into each other. So, using the QI from Time for Care into projects like this, and then using the clinical director role, and then feeding it into everything, really, it all works. It all works together really beautifully.
Thank you so much, Rupert. It's inspiring to hear you talk so passionately about this more proactive model of caring for your whole community. It's a real joy. For people we've got more questions, and I wonder if we'll try and share those with you maybe. I know you've done a few webinars with some of the Time for Care groups about your experience. Are there any particular places, case studies or resources or tips, places somewhere where people can look for advice on getting this started? So
the primary care improvement community, we're going to do a piece on case studies on there, and then you can also go through Time for Care if you're thinking about implementing it. We can help you do sessions with your practice maybe once a week, go through the QI tools that you need to embed it into your practice, and help you along and kind of feed back after you've done it, which I've just almost come to the end of helping one practice in East Essex, who are going to do their postnatal care on the 30th. So I'll be looking forward to hearing how they've done. But yeah, watch the space on the PCIC.
Perfect. So the PCIC, and they have a newsletter as well, don't they? And a sort of a network, online network of resources. And David shared the link for the Time for Care program. Rupert, thank you so much. It's a real pleasure to hear you speak, and thank you for making the time when you've got so much else on your plate.
Thank you for having me. It's been wonderful. It's been a pleasure. Thank you.
Thanks. Thank you everyone for joining us. Really great to have such a vibrant chat going on a previously sunny Wednesday. So thank you for making the time. Nish has shared the feedback link, I think. I'm just checking. Yes, so please do fill that in. It's the bit.ly/webinar 17th of June link. And we really value that. It's a gift we can give back to David and Rupert as well in terms of feedback, but also allows us to, if you've got other things you'd like us to do sessions on in future, or ways we can make these sessions work better, we would like to learn in progress as well. So please do give us some feedback. We've sent out our next gen bulletin just a few days ago. But we've got a whole series of previous webinars you can watch on our website. We've got our new podcast that Nish has been recording with some absolutely inspiring leaders. And we've got a couple more coming up very shortly, so keep your eyes out for those. Dido Harding did our last podcast, which was a really special one. And then we've got a series of short blogs with next gen leaders and senior leaders around the country. And if you'd like to write one of those and share your story and tell us a bit more about you, then please get in touch. We'd love to hear from you. We want to try and make this a really interactive community. So Nikki Kanani is doing our next session on the 1st of July, same time. And then we've got Robert Varnon joining us to help us reflect on the challenges of the last few months before we plan how we're going to get back to a new normal. So thank you all. I'm going to stay on here to carry on, make sure I don't miss anything off this really great chat we've had going. But in the meantime, thank you for joining us, and take care of yourselves until we see you next time.